So we move ahead to the next session. The chairpersons for the next session are Dr. Vipul Gupta, Dr. Kavita Vani, and Dr. Vaishali Shuri. Dr. Arvind Chaturvedi, I think he said that he won't be able to come. He's traveling somewhere. The next chairpersons to take over the session now. Thank you.
We now invite the next speaker. This is a combined session of all the other pathologies, including neuroanesthesia and neuroradiology. So we can now invite Dr. Keshav Goyal, who is additional professor in critical care neuroanesthesiology at the All India Institute of Medical Sciences. And I request Dr. Keshav to kindly start his presentation. Yes, Dr. Keshav.
And I'm audible also. Thank you.
Yes, you are.
So at this outset, I would like to thank the organizing chairperson and the secretary for giving me this opportunity. My topic is dealing with acute neurological emergencies. So the neuroanesthesiology that are dealing with this as a neurointensivist in the casualty as well as in the ICU in day-to-day basis. Now coming to the emergency care burden of these acute neurological emergencies, they form a significant chunk both in the trauma ED as well as in the non-trauma ED. And as far as the non-surgical admissions are concerned, they are almost to the tune of 20% among all acute neurological emergencies. So as we all know, time is brain and every second counts. So to have a rapid assessment and to have a protocolized care is the need of the hour. And for that, everyone who is dealing with these should be on the same page so that we can have a better outcome of these patients. Now, what are the causes of changes in the mental status leading ultimately to the coma? So this can be basically summarized or in a mnemonic. This is A, E, I, O, U, all the vowels and the tips. So basically this comprises all the major causes of leading to the changes in the mental status or coma. And coma may be structural or metabolic to define. Structural, it can be traumatic brain injury, it can be a space occupying lesion, a tumor, a abscess, or it can be a cerebrovascular accident. It can be metabolic on the other hand, it can be due to hypoglycemia, hyperglycemia, hyponatremia, hypernatremia, and so on and so forth. So the coma by any means can be life-threatening because here the loss of airway is there. And airway is the thing, if it is unprotected, it kills first over all other things. So we need to take care of this. Now coming on to the neurological emergencies, how they are different from the other emergencies which we encountered in the casualty on day-to-day basis. First goal is always to don't let the patient die. So we follow the ACLS and ATLS protocol. In the case of acute neurology, we follow the prevent secondary brain injury. Now the second goal is to preserve as much nervous tissue as much possible. This is a little tricky and complicated part of the goal in dealing these neurological emergencies. Now, how it is different, the neurological emergency and the organ, the brain as an organ, how it is different. The CNS is exquisitely vulnerable to ischemia and hypoxia. And it heals poorly. Tissue that dies is not replaced. So we have to be very fast in dealing this and in the record time so that we can salvage the penumbra zone. We can salvage the brain. Coming on to the anatomy and physiology, the rigid non-expansile skull is filled with three things, that is brain, CSF, and blood. They are in the homeostasis normally, but when something like mass comes in, it can be hematoma, it can be edema, it can be tumor, it can be abscess, so on and so forth. So these venous volume and the CSF, they try to compensate. But when the mass keeps on increasing, this limit of compensation is reached. And at this point, even the slightest increase in the volume will lead to precipitous rise in the ICP. This will lead to CPP reduction and herniation. So with this, basically with these differences in the brain, we need to manage these patients. So priority always remains ABC, because you have to stabilize the patient first before going to the investigation, before going to the diagnosis. So you have to stabilize your patient, and that is with the help of airway, breathing, and circulations. Hypotension and hypoxemia, they exacerbate CNS injury directly. Like in this trauma coma data bank study, you can say the hypotension doubled the mortality. And when hypotension was combined with hypoxia, the mortality was almost tripled. So we have to avoid hypoxemia and hypotension at any cost in these patients. So dealing with ABCs, airway is a very important. Open clear airway is the need of the hour. If trauma is there, then it becomes airway with cervical spine. Because unless proved otherwise, these patients can have cervical spine injury. So while dealing with manipulating with the airway, you have to maintain the manual inline stabilization of these patients. Very crucial. Otherwise, the patient will be paralyzed forever. Now, most common cause of seizure deaths is post-ictal airway loss. You are giving drugs to these seizure, you have tackled the seizure, but you are not able to maintain airway, then you are losing your patient. So this is very important. And GCS less than 9, the depth of coma, you need to preemptively intubate these patients. So maintenance of the airway, because this kills first, has to be tackled first. Next comes breathing. Now assess the presence of breathing, adequacy of breathing, and the pattern of breathing. That will tell you a lot of information where the pathology is, and assist if the respiratory rate and tidal volume is inadequate. In a trauma patient, patient can have hemothorax, patient can have pneumothorax. You need to deal with it because they may precipitously lead to poorer outcome in these patients. Now circulation. Generally in a hypovolemic shock in the trauma patient or in a shock state, patient, the blood pressure can be low. So you have to give fluids, preferably the isotonic crystalloid, that is normal saline. Now, in some other scenarios of the acute brain injury, like the stroke and the hemorrhagic stroke, you have to maintain an optimized blood pressure according to the pathology, according to the what is the region. So you have to optimize accordingly. And then after you have optimized it, you have to take care of the dextrose as well, because in most of the trauma, the hypoglycemia may be the cause. So 50 ml dextrose 50%, you can give in this malnutrition chronic alcoholic patient, thiamine can help, and naloxone to take care of the opioid toxicity. So with all this, most of the acute emergency in the coma cases are taken care of. We have to do frequent neuro checks and monitor vitals every 5 minutes in the acute hours. Followed by this comes the history, which is key to diagnosis, the circumstantial evidences that will tell you what is the actually we are dealing with. Key elements are time of symptom onset, and last time the patient was seen normal, whether it has developed over minutes, seconds, or hours. So that will tell you a lot of information. Then you have to assess these 4 things. That is depth of coma, the pupils, size and reaction, respiratory pattern, and motor function. Let us deal with them one by one. Glasgow coma scale to see the depth of coma. So this is from 3 to 15. This is very commonly used because easy to use, less interoperability, good predictor of prognosis. But what are the fallacies with this? There is no pupillary examination. The patient, those who are intubated, it is not useful and does not consider the respiratory patterns. So the 4 score has come in, which contains the brainstem reflexes and the respiratory pattern also. But these both have been compared, and still there is no edge of one over the other. Still basically the more user friendly still remains the GCS. Pupils, you can examine the size of the pupil, and the reaction will tell you a lot of information what you are dealing with, what is the prognosis of this patient, how to go about. And of course this pupillometry can be more objective. They will tell you the exact size and the reaction of the pupil. This can be used. Respiratory patterns will tell you what pathology you are dealing with. And again, the motor posturing, the decorticate and decerebrate will tell you where the patient lies and what can be the prognosis of this patient. So after this, you have to go for the imaging and labs. Like labs, if the patient is not structural, so then that will do hypoglycemia. You can find out the electrolytes, the uremia can be found out from the labs. And imaging, the non-contrast CT is the investigation of the choice in acute neurological emergency, because it's fast, widely available. Will tell you how to go about in a lesser time, because time is brain. CSF lumbar puncture can tell you what the CNS infections, meningitis, subarachnoid hemorrhage, and also albinocytological dissociation in the Guillain-Barré syndrome. So this is a standardized algorithm which we can follow. If a patient of coma, you have to stabilize the ABC with cervical spine, take a focused history, which is the key to diagnosis, and then neurological assessment, and accordingly go for the lab investigations to find out whether the structural cause is there or non-structural is there. If non-structural, they can be hypoglycemia, hyperglycemia, and electrolytes. And if it is a structural, you will do the brain imaging and will find out whether it is a trauma, tumor, hemorrhage, what is you are dealing with. And accordingly, you will go ahead with the management in a lesser time, because all the clinicians are on the same page by following this. And then checklist should be there in the first hour, which is very important to do the things in a fast manner so that we do not miss out on anything. ABC and spine, blood sugar, narcotic overdose, and all those things which we have done should be ruled out. Thus, we have done, we have not missed out on anything. Similarly, the algorithm for the TBI patient, as well as the patient with the mechanism of injury, there is a trauma, patient comes in, you go for the primary survey. You do not go directly for the CT. No. First of all, you have to stabilize the patient, and that is airway with cervical spine. I'm highlighting airway with cervical spine. You have to always take care while dealing with the airway, cervical spine. Then B, for breathing, the patient can have hemothorax and pneumothorax. In this, you have to take care of that. Circulation, you have to take 2 bite-bore cannula, give crystalloids, and if required, the blood to be arranged. You have stabilized ABC, then go for the C, and then assess what is the GCS of the patient. If the patient GCS is still low, consult neurosurgeon early and involve. Exclude systemic injury. And at this time, simultaneously, you can also do the CT and find out what you are dealing with. And then accordingly, go for the secondary survey, treat raised ICP, prevent seizures, correct coagulopathy, and analgesia and sedation. Again, wherever you are transporting the patient from one center to other or from the periphery to, so you again have to checklist, and this is again in the form of A, B, C, D, E. Priority first, what kills first has to be at the top. Coming to the next emergency, the ischemic stroke. The goal is to maximize perfusion to limit infarction, and we have to do it as fast as possible. And this can be done by reducing the door to needle time by protocolized care. Here, the blood pressure, I would like to hear, we do not treat hypertension if it is more than, it is in the below 220 by 120, if there is no end organ dysfunction. Of course, if the patient is a candidate for tissue plasminogen activator, then of course 185 by 105. Now, generalized convulsive status epilepticus can occur in any of this trauma, anything. The most important modifiable element here is time. You have to treat the seizure as early as possible. Why, whatever, you have to avoid the seizure. The drug of choice is lorazepam, but if you do not have lorazepam, you take any benzodiazepine available and use any route, because if the IV line is, you do not waste time. So any route, IM, intraoral, per rectal, IV, whatever, so is available, you just try to avoid, because that decides the success rate in the future course. And prevent future seizure, you have to take specific, avoid underdosing. If a patient is of, you have loaded with 1 gram, the patient is of 70 kg, so it is underdosed from it. It is 1 gram is for 50 kg. So these all things, simple things are very important in successful treatment and better outcome of these patients. Again, following the algorithm, identification of status applicable, emergent management of ABC, the priority, control with the drugs, and if seizure activity controlled, you can titrate the drugs. If not controlled, refractory status epilepticus. I'll be just message.
10 seconds remaining.
I'll just time is brain and just take home message. ABCs are the important in acute neurological illness. Rapid diagnosis and treatment are crucial, which is based on the circumstantial, the history taking, and of course the examination of these patients. You have to look your patient crucially. Ischemic stroke, don't lower BP and open the vessel as soon as possible. In the intracranial hemorrhage, lower BP and correct coagulopathy to reduce the hematoma. In subarachnoid hemorrhage, maintain BP and secure aneurysm by coiling or clipping as soon as possible. Meningitis, give antibiotics as soon as the diagnosis is considered for the LP. And the special thing is myasthenia gravis or GVS, respiratory failure is sneaky. Do not look your patient, the subtle signs. The patient can have shortness of breath using accessory muscles. So do not go on the AVG. The patient, you need to preemptively intubate these patients to avoid the respiratory catastrophe. So again, time is brain. So to end my scenario, do the basics right, rest will follow. You can see the Dravid was there continuously, just doing with a straight back. Thank you.
Excellent talk, and you've almost kept your time. So that's really nice and very considerate of you. We can now invite, are there any questions from the house, please? Dr. Vipul Gupta is the Director of Stroke, Neurology and Neurointerventional Surgery at the Artemis Hospital, Gurugram. And he is one of the pioneers in establishing all the neurointervention services in Delhi. I invite Dr. Vipul Gupta to please take his talk on mechanical thrombectomy in acute stroke.
Hi, good afternoon, and thank you for the invitation. I'll just go on share screen. So I'm going to talk about some tips and tricks in large vessel occlusions in acute ischemic stroke in terms of how do we do the thrombectomy. And all of us know these were the major randomized trials which turned out to be very positive, that in major vessel occlusions, mechanical thrombectomy is hugely beneficial for the patients. All the initial trials by and large use stent retriever, solitary stent retriever, where you cross a microcatheter, deploy the stent and inflate a balloon guiding. In that era, many centers were not using balloon guiding, and you take out the clot with it. These are this basic technique which was described, and these guidelines came in 2015, in which by and large, whenever there was a patient was well preserved before major vessel occlusion, NHSS more than equal to 6, aspects of more than equal to 6, that means not a big infarct, significant deficit, and we could do the treatment in 6 hours. One could go ahead even after giving IV TPA. The guidelines have been revised after the Dawn trial and Diffuse 3 trial, which were delayed interventions. And therefore, they say up to 16 or maybe up to 24 hours, we can do the intervention. So like this patient, a 65-year-old female, wake-up stroke. Previously, we couldn't have done it, but after the extension of the window, there is a MCA block, not a big infarct. Nowadays, we could go ahead. IC occlusion is there. We deployed a stent retriever and recanalized with a pretty good outcome. So what are the technical tips and tricks? How do we improve our outcomes in these patients? So what we want to do nowadays is get the clot in first pass. We are calling this as first pass effect. What studies have shown that even first pass we get a complete recanalization, somehow the outcome is much better than trying to get in 2 or 3 tries. So one thing which has now come in, we always like to use balloon guiding. We always like to use long stent retrieval, like Solitaire 440 is our favorite, because that helps in retrieval. We use push and fluff technique, and we do aspiration as well. I will show you. So this what the study which has shown that whenever you're using whatever stent retriever you're using, when you're using balloon guiding catheter, the flow arrest and even the flow reversal we achieve, that leads to much better outcomes as compared to without using balloon guiding catheter. So nowadays, whenever we are using stent retriever, we use balloon guiding catheter. Number 2 was that if you're using a short solitaire versus a long solitaire, so we can deploy it more distally, it helps in trapping the clot much better. So whichever stent retriever one is using, one want to use the longer stent retriever than the shorter one. Third is that we want to use what is known as push and fluff technique. So in that technique, what we do is initially we release the stent retriever and then we push it out. When we push it out, it opens much better and leads to much better recanalization. And the reason is that if you're just delivering the stent retriever, it sinks into the clot, but only a little bit. The green is the clot here in one of the studies they showed. But when we push it out, it opens much better and it engages the clot much better. And in my own practice, I've seen much better recanalization since we started using these techniques as well. And that is what is helping us to achieve very quick recanalizations. Like this patient, CT looks good. There is an MCA occlusion, big hypoperfusion. At a 10-13, we puncture tortuous anatomy. One can see it here. We use the there's a loop in the MCA. We deploy the solitaire, and you can see it is well open in spite of the loops is because of the push and fluff technique. And in one go, we get all of this clot out and the artery is well open. Single pass, or 10-13 you puncture, and 10-25 you achieve reperfusion. And almost always when you get the clot out in first pass, somehow we get much better outcomes. Now, as we're talking about techniques, sometimes there's a different techniques which may work better rather than just the stent retriever. So another technique which came in is the ADAPT technique. It's a direct aspiration first pass technique. That means take a wide bore catheter and through that just aspirate the clot out. So in some of these situations, it may work very well. For example, in posterior circulation, because it's a difficulty to use balloon guiding catheter. So it is some people have shown that whenever there is a meniscus signs, when we know is an embolic clot, the first pass aspiration works better than stent retriever. Like this patient, she was in hospital stroke, major vessel occlusion, basilar artery, large floating clot. In one pass, we got a large clot out of the basilar artery with almost complete recanalization, except for very small embolism in the left PCA, and patient made almost a complete recovery. And again, we can modify the techniques further. We can use combined techniques. In some situations, we use combined, like this patient, again, major stroke. You can see blooming on the SWI. It's a RBC-rich clot, very tortuous anatomy. We knew we couldn't get a balloon guiding across. So what we do is we did a wide bore neuron max across it. Middle cerebral artery is occluded. And then we combined, this is an aspiration catheter, right at the clot, as well as 3 dots of the solitaire. Both were deployed, what we call a Solumbre technique, and we aspirated through this neuron max high up, and you get a complete recanalization in one go. So sometimes, as I said, solitaire may work with balloon guiding, sometimes use aspiration, and now we're beginning to know when we may use combined technique, particularly when the approach is tortuous, balloon guiding cannot be placed in the ICA. Then combination of guiding catheter, aspiration catheter, stent retriever, the combination technique may work better. Another challenge in technical terms is when there is associated intracranial atherosclerotic disease, like this patient with a stroke, the ICA was occluded, but we could see a very good collateral there, and combined technique was used. In this case, whenever possible, then we even use a balloon guiding catheter as well as aspiration, as well as a stent retriever, what is sometimes known as badass technique. There's a full form I will not go into. So this is so that you are combining all 3 methods at one go. You recanalize, but there is a residual stenosis there, which was the cause of the initial clot. And in some of these cases, you have to recognize that there's underlying stenosis, the artery occludes very shortly again. So now we go ahead and we do angioplasty, and then we wait for a while. So whenever there is ICAD, one has to watch, the artery may occlude or may not open up. We like to do angioplasty in these cases. If angioplasty doesn't work out, then we go ahead and do stenting in emergency. Another challenging point is the tandem occlusions. What are the techniques one can use? Tandem occlusion means when there is an IC occlusion, like because of atherosclerosis or because of dissection, associated with distal occlusion. This is separate from just terminal ICA. The ICA is collapsed because of a distal clot. That is not tandem occlusion. That is just ICA occlusion. So how do we do it in our practice? We just cross the stenosis with a micro guide wire, and I like to do angioplasty in that section. Then we take our guiding catheter, balloon guiding catheter across it, and then we complete rest of the process. For example, this patient with an infarction, not a big infarct, MC is occluded, but you can see there is a clearly calcification. This is atherosclerotic occlusion of the IC as well. This is what we have done. We have crossed it with a wire. We check we are in true lumen. We do a small angioplasty. Then we have taken our guiding catheter across. Then we quickly recanalize the middle cerebral artery. We don't worry about the proximal at this stage. You get the distal reperfusion going. Then we come back, and this is the stenosis here. We do small angioplasty. We wait for a while, and usually in our practice, we inject some antiplatelet agents so that we avoid actually placing a stent, so that because most of these cases, there is an acute platelet reaction going on in this ruptured plaque. We try to stabilize it, we watch it for a while, and if it remains fine, we leave it there and call for stenting later on. In some of these cases, one has to go ahead with emergency stenting as well. So I'll just try to summarize things. Now, stent retrieval with balloon guiding technique works very well whenever there's a RBC-rich thrombus, because the stent sinks very well in it. One second, sorry. Okay, and there is a blooming on SWI, which tells us that we can do it. And when there is a favorable anatomy, that means there's not much kinks and tortuosity, so we can place a balloon guiding catheter and MCA straight, because then where the stent retriever engages the clot very well, this technique works very well. Aspiration alone, if you for some reason it's fibrin-rich clot, the stent retriever doesn't sink into them very well, it doesn't come out very well. Or when there's a tortuous anatomy, I say you cannot place balloon guiding catheter, And particularly in posterior circulation, we know we cannot place balloon guiding catheter, then aspiration alone as a first approach as a technique works pretty well. Combined approach, there are some centers in the world which use combined approach in every case. In our circumstances, to me, these emergency cases, the cost factors is also there. And I don't think there is a strict evidence that combined approach is much, much better than other techniques. But when there's a mixed clot or there's a tortuous anatomy with RBC-rich clot, suspected ICAD, and distal occlusions, then these are the cases in which we like to go ahead straight away with stent retriever as well as distal aspiration techniques. So I just want to conclude my talk that tips and tricks in thrombectomy, that means proper case selection is important. And the first pass technique, as I mentioned, taking those long balloon guiding, long stent retriever, push and plug technique with strong aspiration, that really helps. Appropriate technique, one can start switching to direct aspiration or a combined technique in particular circumstances when we know they will work better. And as said, one should have strategies for intracranial atherosclerotic disease and tandem occlusions, because they will need some other angioplasties, sometimes stent placements or acute antiplatelet agents administration will be needed as well. Thank you.
Dr. Vipul, that was an amazing, clear-cut talk with, black and white, totally black and white. You've laid to rest all the controversies about, to tackle the distal first or the proximal first. You laid to rest and make it very cut and dried. Amazing. And you kept to time. So that's really amazing. So right in the beginning, you get a large infarct. Are there any, is the attitude changing to it now?
So, okay, as the guidelines mention aspects more than equal to 6, but there's not a lot of data coming in that some patients with largest infarcts may also benefit, particularly when aspects is around 5 or so, okay? And so in my practice, when we have a young patient, more towards right-sided infarct, larger-sided infarcts may improve more than the left-sided one, particularly when there's a large infarct, but the motor cortex is spared, aspects is around 5, and it's not very late. That means patient come at 3 hours with the largest infarct, young patient, right-sided, motor cortex is spared. Some of these patients may benefit, and I think we can offer them. There are many centers in the world which are practically rushing in all large infarcts and doing thrombectomies. I don't think that strictly the data is there for them. In their practice, they say there is no harm, but Indian patients are paying from their pocket. They expect some improvement. But definitely, as I mentioned, some selection of large infarcts may benefit from thrombectomy.
Amazing way to deal with these changing paradigms now. Now we have we are not really strictly sticking to time. Even for TPA, there are many studies coming in that one does not have to stick to 4.5 or 6 hours, and they are also looking at the perfusion and whether they can give IV TPA even beyond the current guidelines. Amazing talk, sir. Would the house like to make a comment or ask a question?
Can you see it?
Yes, we can see your screen. It's full screen as well. We can hear you. You may continue, sir.
Thank you very much. Good afternoon, and it's a pleasure to speak on this forum. Takes me back many years when DNA was formed, and I was the informal secretary at that time for nearly a year or year and a half. It's wonderful to see that it has flowed into such a wonderful organization. Today, I'll be speaking on artificial intelligence in neuroradiology. Most of the work I'm going to show is work that we've done at Margin Imaging and at Caring, which is our Center for Advanced Research in Imaging, Neurosciences and Genomics. And really, we are all very excited about where it is and where it can go. Now, what is artificial intelligence? The term is not new. It was coined in 1956 by John McCarthy, and it really refers to ability of computers to learn without being programmed. It's gained recent popularity because of the exponential increase in computing power. Each of us carries a supercomputer of old in our pockets. And the new approach, such as deep learning, which came as recently as 2016, it has huge implications and applications. And basically, what is AI is using high-end computing to find hidden patterns in data. And there is significant overlap with the field of computational neuroscience. It has also been said that AI is whatever machines can't do yet, since what constitutes AI and what does not is constantly changing in a matter of weeks, months. What are the types of artificial intelligence? We have artificial narrow intelligence, and this is something which I think all of us remember. Deep Blue winning against Garry Kasparov, the chess champion of the world. And then we have artificial general intelligence, which is the emerging field. This is the next frontier. Human beings are here at this stage, and this is where you teach one kind of application to a computer, and it's on its own, it's able to learn something else. Like AlphaGo, a computer is able to learn, which is a very complex Chinese game. It's able to learn on its own once you've taught it chess and shogi. And this really is the area on which most of AI is working right now. And then we have the area of artificial super intelligence. And the world is divided about this possibility. This actually describes the point in time when AI becomes stronger than humans and the computers will rule the world. We do not want to believe that this is possible, but we've seen, if we go back, all the science fiction books we read, most of what people imagined at that time has come true. So the limitation really is the imagination that a human being can have. If we show or we want that something be done, there is a scientist, there is a wonderful human being sitting somewhere who will try to achieve it. Now, learning or training is the fundamental basis of all AI today. This is the traditional technique, and most healthcare AI is focused on this. This is labor intensive. Knowing the ground truth is vital. Higher accuracy is achieved when the labels are better. So Facebook's face detection only works once enough pictures of people are tagged by users. Chest X-ray algorithms require thousands, in fact, lakhs of labeled images, which have been seen by good radiologists, where the findings have been tagged, and using that, the computer on its own is able to recognize patterns and then be able to differentiate whether it's pneumonia, whether it's tuberculosis, whether it's malignancy. So that is how things are working now. How is an AI algorithm developed? First, we have to find data, all our scans. Then, using those scans, we train a model. Then we validate the model, and then finally test the model before it can be brought into the clinical realm. And this validation and testing is where Caring has done some unique work, globally published it, and I'll probably share some of it with you, because you cannot have an unsupervised algorithm which will do reporting on, say, a head CT on its own without validating the model, testing it, and then deploying it. Now, examples of AI in neurology and neuroimaging and neuroimage acquisition. This is something we presented in 2019 at the ISMRM and at the ESR. This is being able to take a T2 weighted image and the AI algorithm actually predicting or showing us a T1 and diffusion weighted images just from T2 weighted images. This is virtual MRI, and I show you some examples. This is an input T2 image. This is the actual diffusion image. And here you can see there is this area of a chronic infarct, ischemic demyelination in the left frontal periventricular region. And this is actually the virtual diffusion image. So this image is what was shown to the computer, from which it was able to develop this. And below is another case where you have, this is the T2 weighted image, that's the true diffusion, and this is the virtual diffusion, where even though the human eye cannot differentiate between chronic and acute infarct, which a diffusion weighted image can, the computer, after teaching it, was able to make this differentiation. And this is something which really startled the world, that this was possible. This is another case, a T2 weighted image, multiple periventricular hyperintensities, including this one in the thalamic region. And they are all bright on T2. That's the actual diffusion. And this is the virtual diffusion. And here again, it's able to differentiate chronic infarcts from acute infarct, something which was very, very surprising to us. And even smaller lesion, which multiple small T2 hyperintensities, this is the actual diffusion, and that's the virtual diffusion. So even the small acute infarct in the head of caudate nucleus has been picked up. So this can have a lot of connotation for the future of MRI, where suppose today we need to do 7-8 sequences. Suppose it was possible just to do 1 or 2 sequences and be able to generate the others using AI. That would shorten an MRI exam to less than 5 minutes, and so which can be hugely important for the patient throughput, the cost of the MRI scan, and so on and so forth. Then there is the automation of the MR protocoling process, where automatically the machine itself, using AI, you tell it that I want to examine the hippocampus, and it places the slices itself. And when there is a examination done 3 months later, those slices will be replicated exactly, so that between scans and for all scans, the cut lines are placed in a similar manner. This is something which is already available in some of the machines. Then using AI, and this was again a wonderful work, not done by us, but reconstruction of 7 Tesla-like images from 3 Tesla. And here you can see that these are axial views, and this is a 3 Tesla image. That is what it looks like. That is a 7 Tesla image, and you can see much sharper, much more definition. And the same 3 Tesla, now you're able to reconstruct using AI, and you can see that they look very, very similar. That's the ground truth 7 Tesla. This is 3 Tesla using AI, giving 7 Tesla-like images. This again has a lot of potential. Maybe from a 1.5 Tesla scanner, we can get 3 Tesla, and from a 3 Tesla, get 7 Tesla-like images. This is another case, improving the signal to noise ratio of ASL MRI, and this is perfusion, arterial spin labeled perfusion without using any contrast. And this is a low signal. We get very low signal. Usually this is a 2-minute scan, that's an 8-minute scan. And using AI, this 2-minute image can be reconstructed to an 8-minute image. The quality, this is synthetic ASL produced from a low SNR, signal to noise ratio image. Super resolution. This is a deep learning model, and we are working with a group out of Stanford called Subtle Medical, where there is 3x resolution improvement using, this is acquisition in 4 minutes, 46 seconds, that's in 2 minutes, 34 seconds, and you're able to improve it and get better resolution. So this is again, do a low resolution image and using deep learning, be able to get higher resolution, save time, get better quality. This is another collaboration again between Caring and Subtle Medical out of California, where that's an 8-minute scan for the brachial plexus. This is a 3-minute, 22-minute scan, a 3.22-minute scan. And this is the same using DL, you're able to get resolution, which we got on an 8-minute scan. So these are phenomenal advancements that are occurring, and hopefully in the next year or two should come into clinical practice. This is another machine, deep learning based image recon, low dose CT. This is already available in the market, FDA approved. So you give very low dose on CT and you're able to generate excellent quality images using that. Post-processing, this is again work done by us in our center, development and validation of a deep learning based automated lumbar spine canal segmentation and measurement tool. So automatically it'll measure the AP, it'll measure the area, it'll measure all of these automatically on to know whether there's spinal canal stenosis. And this is developed by Synapsica, another group in Delhi, where it gives you the height of the vertebral bodies, it gives you whether there's spondylolisthesis, what is the degree of that, all of those in just automatically without you having to do anything. And this is the most amazing advancement. This is an algorithm that's available. This is out of a group called KIBIM in Spain, and this is a case of MS. It counts the number of MS plaques, it gives you the exact volume, and also temporal change when you do a repeat scan. So making a doctor's, a radiologist's job that much easier, that much more accurate. Then in diagnosis, the holy grail is when machines will start replacing the radiologist and giving the diagnosis itself. This is our paper, which was published in 2018 in the Lancet. This is the first paper ever to be published on AI in the Lancet. Deep learning algorithms for detection of critical findings in head CT scans. And here, automated detection where it shows you intracranial bleed, fractures, midline shift, also gives you an automatic report. Picks up the fractures very well, midline shift, the volume of the hemorrhage, whether it's subarachnoid or not, all of those very, very well. Now, just a word about caring at the end. Caring is incubated at Margin Imaging, and this is the Center for Advanced Research in Imaging, Neurosciences and Genomics. We have the Caring AI platform, which is already in use at Thomas Jefferson. It's used in multiple institutions across the world. And we also have Caring DX, where we do next-gen sequencing. And we are building the world's first end-to-end validation and deployment platform for medical imaging of AI. Now, in conclusion, I would say that AI will not substitute doctors anytime soon, but AI, which analyzes only images, will do some machine-like human functions in the next 5 to 10 years. It'll auto-measure everything. It'll flag studies with clinical findings. It'll identify normal scans, be able to differentiate normal from abnormal, whether it be a chest X-ray, a head CT, or a mammogram. It'll auto-pull relevant data from EHR systems. And in conclusion, I'd like to say that there is a lot of fear in the radiology community about artificial intelligence because people think this will, replace radiologists. But I'd like to say that when technology is useful, we have to adopt it, we have to adapt to it, and we have to change before we have to. Something said by Jack Welch in a different context. And also he said, control your own destiny or someone else will. Thank you so very much for giving me this opportunity to present our work today. Thank you.
Dr. Mahajan, we are totally blown over with this amazing work that you have been doing. I have been following your talks for the last couple of weeks, and I'm absolutely flabbergasted. And I'm wondering why I did not, try to collaborate with you earlier.
We are always open.
And I really would love to.
We wouldn't have been able to do this. We have 35 collaborators across the world. We work with the IITs, with JNU, with All India Institute, We work with MIT, we work with Stanford, Harvard, I mean, you name it. I will just say that
Can I ask a question to Dr. Harsh?
Working,
I'm Dr. Devashish here.
finding collaborators
Yes,
in India. Somehow.
Yes, please,
There
Dr.
is
Devashish.
this, private versus government thing, which is impediment. But, we are absolutely open to collaborations. Thank you very much for your kind words.
Dr. Harsh Mahajan,
Harsh,
this is Gauri Devi here.
Yes, ma'am.
We
Good
are also
afternoon.
collaborating with you for genomic studies or monomilic
Absolutely.
hemorrhaphy.
Absolutely.
Yeah, we got some very interesting results from your lab. Thank you.
Thank you, ma'am.
Dr.
Dr.
Harsh, can I
Devashish, sir.
ask you a question?
Yes, Devashish.
So you have said, obviously the huge potential of this, new age imaging. But I would like to know that what is still the error rate? What has been the error rate? Because that is very important, because, you can, machines can also do errors. And what is the, scale of errors in this?
Devashish, you hit the nail on the head. And that is where caring is actually doing the major work. We are, even if I'm saying it, but our group is the leader in this across the globe. And this is because I make a AI algorithm and I say it is 99% accurate. Will you believe it? You will not. Will you use it on your patients? You first have to validate it on your own data. You have to test it on your own data before you can start using it. And that's where, that Carpal, the platform that we have built, the Caring AI platform, that is where it comes in, where, just as when you get a new machine, whether it's for electrophysiology or a MRI or a CT, we fine tune the machine before we start scanning patients on it. Similarly, we believe, and this is a concept which our group has given to the world, that whenever you get an AI algorithm, every individual institution, every radiology, neurology department will first have to run it for a week, 10 days, 2 days, whatever it takes, on their own data, see how it works. And within Carpal, we have the tool which can tweak. You may say, I want 100% sensitivity. Let the specificity be wrong. It doesn't bother me. I don't want to miss abnormal. Okay?
Dr. Harsh,
Even if
we'll have
the...
to move on to the next talk, if you don't mind.
I'm sorry. I could go on and on.
All right.
I know that. I wanted
to ask a
Nice
question,
talk,
but I will ask you
Harsh.
directly,
Nice
Dr.
talk.
Mahajan. Wonderful.
If Dr. Deepti is ready, ma'am?
Yes, I'm ready.
Okay, Dr. Deepti is going to tell us about neurosonology and OPD practice. Dr. Deepti has been my teacher. She's working as a professor in neurology at the All India Institute of Medical Sciences. Ma'am, could you please share your screen?
Yeah, sure. I'll just do that. Yeah. Is it okay?
Perfect.
Yeah.
Yes.
So thank you, the organizing chairs, and Dr. Kavita for the kind introduction. So yet not a professor. Right now I'm an additional professor. So I'll be talking about applications of neurosonology in outpatient clinic. I have spared the emergency indications because that becomes a separate topic in itself. So when we talk about neurosonology, it basically encompasses three structures related to the nervous system, which we can image. Namely the transcranial Doppler, the carotid arteries, so the transcranial Doppler for the intracranial vasculature, the carotid vasculature, carotid duplex Doppler, and notwithstanding the peripheral nerve ultrasound, which I feel is grossly underused. So I'll be talking a bit about all three of these in the limited time, and I'll be taking it case-based so that it becomes more contextual. So first, talking about transcranial Doppler, broad indications are basically to look for the real-time hemodynamic disturbances in intracranial circulation. As we know that when we talk about, transcranial Doppler imaging, vis-a-vis other modalities, namely the gold standard, which is to be the DSA as well as CT angiogram. They are basically luminograms. So they tell you about the lumen characteristics and lumen behavior. Vis-a-vis, when we want to look at the hemodynamics, when we want to look at actually the real-time hemodynamic disturbances, then the transcranial Doppler is something which is the modality of choice. And also to see for the evidence of emboli in real time as well in proximal arterial or cardiac source of the thrombus. So we'll be talking about this in a little more detail when I go through the cases, and to examine the cerebrovascular reactivity and vasomotor response to intracranial stenosis, in intracranial stenosis. Now, this is something, again, which is very unique to this imaging modality. Because to look at how the cerebral hemodynamics is behaving to hypoxia, to CO2 retention, is also something which we can only do by this modality. So when to do or when to ask or when to request for a transcranial Doppler. So here is a scenario in which a patient with left hemiparesis who recovered over 1 month comes to the outpatient with a CT angiography, which shows complete occlusion of the right internal carotid artery. So nothing to be done there, but he also has 80% stenosis of the left internal carotid artery. And he wants to know if his left ICA needs intervention. Now, technically speaking, this is asymptomatic carotid stenosis, but definitely critical, and in a patient who has already had a stroke earlier. So the questions which we need to ask, now he's come with a CT angiography. So do we have a better test? Do we need a better test? Is TCT going to help me in deciding the treatment? And what do I need to tell my patient, and of course myself, while interpreting the results of the TCT when I get one? So when we look at the odds ratio of, how will the TCT help me? So if we find spontaneous microembolic signals on the TCD, on the right side, which is the asymptomatic side, then the odds ratio, if you find MES, are very high. It's 2.24 to 24.89. And if we find spontaneous MES on TCT, plus we do a carotid Doppler and we find that there is an equolucent plaque, then it further increases a probability of having a doing an intervention basically. So now this is a meta-analysis which was published in 2020, which looked at all the other tests which we can have in dealing when we have an asymptomatic carotid stenosis. So any features were studied in 64 studies, and that showed that, if you find equolucency of the plaque, if you find that there is impaired cerebrovascular reactivity, if there's an intraplaque hemorrhage, if there are ipsilateral silent brain infarcts or a lipid-rich necrotic core, all these increases or places the patient as a high risk for having a stroke in the same territory. To elaborate on that, when we look at the silent brain infarcts, we can basically, image that via the MRI. We can look at the intraplaque hemorrhage and equolucencies with the carotid Doppler. And for impaired cerebrovascular reactivity, we use the transcranial Doppler. So these are the modalities which can help us for risk stratification in these patients. So again, microembolic signals, as I told you earlier, will increase the chances that this patient will have a completed stroke. So it gives us more conviction for intervening such a patient. Having a mural thrombus, neovascularization, plaque irregularity, ulceration. These are all characteristics which we'll get in a carotid duplex Doppler, which will help us to characterize and risk stratify such a patient. So what do you do in these patients? You first look at clinical examination to look for human signs in the affected territory. Yes, if you get that, then all these fancy tests are basically for, putting in more ground and justification. You do a TCT to look for MES and cerebrovascular reactivity. You do a carotid Doppler to look for plaque characteristics, and an MRI brain to look for silent infarcts. Then, again, so the next indication, which I'll be elaborating by an example, is a 30-year-old patient with stroke who comes with normal vascular risk factor workup, and he's been referred for evaluation of possible, patent foramen ovale. So, and a transthoracic echo does not reveal any PFO. So, Another indication of doing a TCD in young patients with stroke who have suspected PFO but are negative on transthoracic echo is a bubble study. So how is it different, or how is it comparable when you do a transesophageal echocardiography? So this was a comparison between TCD and TTE, taking TEE as the gold standard. Now we can see that when we look at TCD versus TTE, they are almost comparable with a very high likelihood ratio. And any likelihood ratio which is more than 10 is said to be pretty fairly diagnostic of that test, and negative likelihood ratio of anything less than 0.1 is again said to be pretty diagnostic of its negative value. So we can see that if we find echoes or hits on the transient signals on the bubble study in a TCD in a patient with PFO, then we can have a high level of suspicion that this patient might have a right to left shunt. So this is almost like a curtain formation in a patient with a bubble study who had a PFO. So that is another indication in which you should ask for or request for a bubble study in patients who have young stroke, and before labeling them as cryptogenic, and if they are suspected to have a PFO. The practical advantage of doing a bubble study over a TEE is that you can get a very nice, and you can even repeat it, and it is very non-invasive. So it's a scenario 3 is a 65-year-old male who is planned for coronary artery bypass graft surgery and is found to have ICAD with stenosis in the left MCA. Now there is no history of stroke, and the MRI brain is not showing infarcts, and he's referred for clearance for surgery. Now this is another tricky situation where you have to clear such a patient. Of course, you can give a high risk clearance in these patients because they have generalized atherosclerosis, but to do a cerebrovascular reactivity in these patients may help you to really stratify the patient's risk for having a intraoperative stroke. So here we do a cerebrovascular reactivity in which we ask the patient to breathe normally and then have hyperventilation or Valsalva maneuver and then hold the breath for 30 seconds. And then we repeat it after 5 minutes. So there are normative values and there are borderline impaired and exhausted, which helps us to give an idea about risk stratification in these patients as well. I will not go into these details of technicalities, and I will move on to the next modality, which is carotid and vertebral artery ultrasound. The advantages of doing a Doppler are that it is non-invasive, it is a real-time information, there's an ease of repeating and monitoring. It is better, as we saw earlier in my previous slide also, that we can, it is better for plaque morphology, and it is reliable in expert hands. Advantages in technology make automatic recordings, which was not there earlier, and it is better evaluation of hemodynamics. So here are the 4 modalities which we can compare, and as we can see, the advantages of duplex ultrasound carotid is that it is non-invasive, has no radiation, no contrast agent. However, when we talk about the limitations, we know that the stenosis morphology is limited as compared to DSA. So when we're talking about, again, it tells about hemodynamics as well as about the plaque characteristics, but not too much about the lumen stenosis. Okay, and here I go on to the last part of my neurosonology paradigm, which is peripheral nerve ultrasound, which is again one of the pretty underutilized imaging modalities, but very useful in real time again, and also for doing interventions, peripheral nerve interventions like. So I'll be talking. So advantages of peripheral nerve ultrasound are basically that if we use high resolution 15 to 18 megahertz transducers, then we can get a clear anatomy of the peripheral nerves. They're more conspicuous when imaged in short axis. So we image that in short as well as long axis. If you see in the diagram here, so this is the long axis in which we can see the radius in the carpi and the nerve. And here we can see in the honeycomb appearance in the short axis. So the cine sweeps of the areas of interest often provide better spatial information than solely relying on still images, because they are cine sweeps and live images. And comparison of the contralateral upper extremity is helpful. If there is a subtle abnormality, then comparing it with the contralateral side is more useful. And I'll show you an example. Carotid Doppler, the color Doppler technique is useful to distinguish, when there are small nerves and you have to distinguish that from the vasculature, then you can use a Doppler to substantiate your findings. And there is a direct correlation when symptoms are elicited during the, so you can apply pressure and then you can localize the nerve pathology, and that's very useful. So the abnormalities that you expect when you are doing a peripheral nerve ultrasound is that if there is an abrupt caliber change, if there's a flattened appearance, if there's a diffuse enlargement like in a neuroma, and if there's a loss of normal fascicular architecture of the nerve, like a honeycomb appearance, which we say, or if there is a hypervascularity or atrophy of the musculature also innervated by the nerve in question, gives you corroborative information that probably there is a problem there. So here you can see this normal honeycomb appearance of the nerve by which you identify, and these are the muscle layers. So that way it is informative. Now we can compare the normal side and the affected side in a carpal tunnel syndrome example. So here you can see the normal nerve outline, and here it is compressed and flattened out. This is in the short axis. And then again, you can see that the fibrous component is more here on the and shortened on the affected side, and is normal on the normal side. So a lot of times comparing it from the normal side also gives a lot of information. Okay. Diagnostic as well as therapeutic. So diagnostic, basically classification and localization of nerve injuries, neuromas, peripheral nerve tumors, and therapeutic. This the last slide. So therapeutic interventions basically for ultrasound guided nerve blocks, as well as ultrasound guided botulinum toxin administration, which is being used in a big way. So thank you for your patient hearing. I think I'll stop sharing the slides now.
Amazing talk, Dr. Deepti. The topic is now open to the house.
This is Dr. Gauri Devi Deepti. Good afternoon. Have you tried to correlate the changes found in ultrasound and your nerve conduction and seen which is more sensitive or whatever?
So
have you tried doing that? Yeah.
So I haven't tried doing that personally, because I've had training, but at AIIMS we are still not having the infrastructure to do that. So I'm trying to get that in. But as far as the when there is a doubt or when there is an intervention required, then ultrasound does help in corroborating with a doubtful electrophysiology. So that way they are complementary.
Yeah, because in NIMANS, Dr. Nalini is doing this, and they try to compare, initially at least, till you develop some confidence in the interpretation, etc. Thank you.
Thank you, ma'am.
Can we move on to the next talk? Dr. Saran is ready, I think.
Yes.
Sir, are you ready, sir?
Good. Yes, I'm ready.
Perfect, sir. Please maybe continue with your talk, sir.
Dr. Kavita, kindly have a check on time, because we are running late, very late.
Yeah. We are running late.
Yeah, very good afternoon to all of you. Hello? Yeah, can you hear me? Can you hear me?
Yes, sir.
We can hear you, sir.
Yes. Very good afternoon to all of you. At the outset, I thank Dr. Achal, Dr. Devashish, and all the team members for giving me opportunity to present this topic that is the Achal has given to me, mimics and chameleons in the muscular dystrophies. You see, when the topic was given to me, I was slightly baffled. Chameleons are the animals, lizard kind, which can change the colors to surrounding. But the most important thing that the eye that moves independent of each other, which was surprisingly new news for me. Also, the Oxford Dictionary says the person who changes his or her opinion or behavior to please others. The opponent called him as a political chameleon, a fickle person. Philosophically, the chameleons are adjusted to the surrounding perfectly and camouflage it so that they can perform the function perfectly they meant for, and they intended to do the function perfectly, very nicely. So they prey their insects. But when this corresponding things, the upper opponent views come to into a picture, that the person who changes his or her opinion or behavior to please others, or fickle persons, or fickle-minded persons, and political chameleons, this means very dangerous. And when we extrapolate this thing for neurologist, neuropathologist, or to the patient, this means very bad to her. And even if the patient, he is having a disease, or say dystrophies in this context, and he's pleasing the doctors, or oppositely perfectly making an undetectable by others clinicians or pathologists. So this means for patient also, these chameleons are very bad things. But for a disease name, nomenclature, or disease course, it makes a sense perfectly that the particular histopathological nomenclature of muscle disease may or may not follow perfectly in the defined pathway, or some way masquerading or mimicking with the other diseases. And that is the perfectly way. So in dystrophin deficiency, we realized it, that the phenotypic mimics are there from DMD, BMD, or maybe X-linked dilated cardiomyopathies, or maybe just IQ problem, dystonia, dysphonias, or maybe behavioral cognition problems, or manifesting carriers, female carriers which are manifesting, or maybe just having the isolated calf hypertrophy or hypercemias, asymmetrical hypertrophy of the calf muscles, or may even have a trap by some evidence having the second affected children even after the negative carrier test, and how this has happened by explanation of the germline mosaicism, the two type of eggs but no mutation in the blood cell from which the DNA mutation for the dystrophin is detected. And similarly for the dysferlin also, we realize that the different site of mutation of the same genes causes the mutation at the different point, either 2B type or Mioshi distal myopathy. There are two clinical presentation of the same gene that we already know. In the case of BMD, that we also know that the course of disease that mimics other diseases, or diseases that changes its course from one to another, because earlier when the dystrophin gene detection sensitivity was low, many of the cases where the ISC markers or the gene detection was not identifying the dystrophin gene mutation, the BMD were called as SMA3. So like this, in this case of BMD, focal area of the clustering of the atrophic fibers are there in the myosin fast. So there is a cases of BMD, which I have told you earlier, maybe these were called as the SMA with the myopathic features. More importantly, when the routine dystrophin gene genetic analysis is negative and immunohistochemistry did not pick up the weak or the patchy staining of the reduction of the or absence of the dystrophin on the sarcolemma. In the same case, I'm showing one example, classical 6-year-old male with the calf pseudohypertrophy with cover signs and other features. The genetic test was ordered, and you realize the genetic test in this 6-year-old child, that the blood analysis from the mixed ligand probe assay for 79 exons, you realize that the dystrophin gene did not show any deletion of 79 exons in the dystrophin gene. So this was the dystrophin gene negative. But when the biopsy came to us, it was a frank dystrophic vessel with marked variation of fiber size, intermycial, perimycial fibrosis, inflammation, degeneration of the muscle, internal migration. And when we did the ISC for the spectrin, the sarcolemmal membrane are intact, but dystrophin either rod domain, C terminus dystrophin 2 or dystrophin 3, N terminus, all they show absence of the sarcolemmal presence of the dystrophin. So they were absent. They were not like a lining brown like the in spectrin. But despite intact membrane, the absence of protein in the by the 3 antibodies shows total absence. So this was a classical case of the uh, DMD. In another situation where the dystrophin 1, 2, and 3 shows patchy expression, these fibers, you realize that these fibers are negative for the sarcolemmal, and these fibers which are dark brown lining are the positive dystrophin. So diagnosis of Becker's muscular dystrophy was offered. But realize that the most important trap is there when the routine dystrophin gene genetic analysis is negative, and the muscle biopsy histochemistry also did not show that the dystrophin stain is weak or patchy, the pathological report will say dystrophic muscles, no evidence of DMD or BMD. Or if we have done the sarcoglycans on the dysferlin also, then we say no evidence of all these things happen. See, when one of the perfectly patchy deficient staining, these fibers have stained properly and dark lining brown, and here the staining of these fibers are patchy and weak. And how to interpret it? Because there is a sensitivity and specificity in the eyes, that the minimal variation of pattern of intensity could not be detected by sensitivity of eye. If that detection is inferior than this, then the ISC even cannot detect the dystrophin 1, 2, 3 at times. And this will be another problem which we are mimicking. So in that case, immunoblot for dystrophin for the Duchenne muscular or Becker's are strongly advised. So impression is presently available microscopic techniques cannot discern a subnecrotic microscopic pathological changes. Pathological changes which are subnecrotic in status, or apoptosis of functional disturbances like ion channel, where the proteins shows functional disturbance rather than the morphological or anatomical presence or absence. And similarly, another problem exists. There is secondary reduction of dysferlin in immunohistochemistry also exists. And the cases of 50% of the sarcoglycanopathies or 20% of the DMD, BMDs can show secondary reduction of dysferlin in their sarcolemma. And this was the book of Carpete says. Then noteworthy to note that the about half of the sarcoglycans and 20% of the dystrophinopathies indicate diminished dysferlin expression, and due to the secondary process related to muscle degeneration. So if we are too much relying on the immunostaining of the sarcolemma by either dystrophins or sarcoglycans or dysferlin, then at times in these cases, because of the secondary reduction of dysferlin, we may be mislabeling these patients as a cases of dysferlinopathy. You see another situation in inflammatory myopathies. Histochemistry demonstration of these and semi-quantitative assessment by the weak protein deficiency or maybe the excess protein by the myofibrillar or desmin myopathies. And in this case, immunoblots are necessary. And these are the inflammatory myopathies, the two subcategories that we say. So pitfalls in histological morphology, when the PM is with the sporadic IBM, inclusion body myositis, or the PM with the necrotizing autoimmune myositis, or PM-NAM with the dystrophies. So even the cases, some cases of the dystrophic patients which have a slow progression may have a prominent inflammation on histology of the muscles. And these are again the very big trap for the neuropathologists or pathologists to assess whether these are the cases of the post-inflammatory myopathic changes or maybe just the LGMD cases. So failure to recognize inflammatory cells in the biopsy, and we all know that the inflammatory cells are always patchy. The other point is the skip lesions. But perivascular atrophy is always a very characteristic of dermatomyositis, and that is the only very important strong point of the dermatomyositis. But polymyositis, the criteria are the very, very problematic. Additional factors that mimicking is the compensatory changes of the muscles which modify the clinical or phenotypic presentation. We know when there is a dystrophin gene mutation, and this leads to overexpression of the utropine. And this expression in the sarcolemma somehow protects this physical and the functional form, but it mitigates the deleterious effect of the dystrophin. So maybe at times there is a severe loss in the ISC level, in the histomorphological level, but clinically the patient may not have that serious expression. The treatment, I know genetic abnormal protein, cell dysfunction, or clinical phenotype. So this is the way the EMQN best practice guideline for genetic testing of dystrophins was offered in the 2020. What
Dr.
in our
Saran, sir,
Indian
30 seconds
scenario,
remaining, sir.
yeah. In the suspicious dystrophinopathy, first step they said after is the genetic testing, and the muscle biopsy in our conditions are done. And with ISC, we decided if the DMD or no DMD, but dystrophic muscles. In the Western things, the first is the MLPA, that is the genetic testing with oligo-based comparative genomic hybridization. And when there is no deletion or duplication, then they do the second generation is the
Concludes.
yes, I'm concluding with
Yes.
this. This level of various small level of missense, nonsense, or maybe indel or splicing variation can be done. Or the third level is the RNA analysis. This copy number variation or single nucleotide variation, and the apoptosis and other thing. But the other important point is the genetic testing are essential for the first choice of diagnosis with carrier detection and prenatal diagnosis. There are level of genetic test that is happening and that we have to see. And however, the muscle biopsy still and the IC remain the gold standard, but this concept is changing. And I see for the dystrophin in our situation was 98% was positive and sensitive, but I realize that this concept of the minor phenotypic presentation maybe that we need to see as a complementary thing rather than as a sole gold standard. Thank you.
Amazing discussion, sir. Most of it went over my head. I need to start learning basics as well. So, for want of time, we will move on to the next talk by Dr. Anshu Rohatgi. He's going to speak on uh, neuromodulation in drug-resistant epilepsy. The risk of being the last speaker, Dr. Anshu, is that you will have to, the onus of saving minutes is on you.
Okay, thank you,
Please
Kavita.
share your
I'll
screen,
just
Dr.
start.
Anshu.
I'll just share my screen.
Yes, please.
I hope my screen is visible.
Yes,
sir.
it is, Dr. Anshu.
Yeah. So I think I'm the last speaker, so I'll just, without any ado, I'll move forward. So we are going to talk about neuromodulation in drug-resistant epilepsy. The ILE has classified drug-resistant epilepsy as a failure of adequate trial of two tolerated, appropriately chosen and used anti-epileptic drug schedules, whether as monotherapy or in combination to achieve sustained seizure freedom. So this is the definition which has been given by ILE. And most of us know that about 1/3 of the patients of epilepsy, despite pharmacological treatment, do not improve. So this is a drug-resistant population that we need to treat. And this is what we are going to talk about, because these patients are not doing well on monotherapy or polypharmacy. So let's see how can we help these patients. So when you have patients with drug-resistant epilepsy, you have a lot of psychiatric issues like depression, anxiety, increased mortality and morbidity like with SUDEPs, the long-term side effects with the anti-epileptic drug use, and of course, cognitive and seizure-related injuries. And of course, you are not able to work full-time and unable to maintain social relations or establish a family or remain in education. So it's a lot of consequences of drug-resistant epilepsy. So it's important to treat these patients. So especially about the incidence of uncontrolled seizure leads to 10 times increased risk of premature death. And this is really very surprising. So you have the sudden unexpected death or SUDEPs occurring in these patients. Then you have the sudden cardiac death, an increased risk of accidental death, and a status epilepticus, which can also cause a premature death. So it is very, very important to treat these drug-resistant epilepsy patients in a proper way, because we know almost 1/3 of them cannot be treated with single therapies or polypharmacies. So important to identify these patients very early in the disease, because now we have a number of modalities that can help these patients prevent these seizures, and we have a better quality of life. So when you evaluate a patient with a drug-resistant epilepsy, the first you have to confirm that the patient has an epilepsy. Then you have to confirm what kind of seizure type the patient is having, and then you select the treatment. So the various treatments that we look forward in these patients are basically you talk about the cranial surgery, which include the responsive neurostimulation system, the RNS, the deep brain stimulation. Then you have the resective surgeries like the hemispherectomy, the corpus callosum, or multiple subtalar transections, and of course, the MR laser ablation. And of course, the ketogenic diet, the modified Atkins diet, and the low glycemic control. And of course, the vagus nerve stimulation. So these are the non-pharmacological approaches when you treat such a patient of drug-resistant epilepsy. So, so about 30% of patients of epilepsy continue to have seizure despite treatment. And some of these patients epilepsy surgery may be a good treatment option. And surgical resection may help these patients having a good long-term outcome. However, the problem with surgical resection is that some of these patients may have a long-term memory deficit, especially when the removal is on the left side. Children may benefit from surgery as brain plasticity may facilitate a post-surgical reorganization in a better way. And there is definite evidence to indicate this surgery is an effective option for some of these patients of drug-resistant epilepsy. Now, these are some of the procedures that one does, and one, of course, knows about most of these procedures. So what happens when we are not able to take these patients for surgical? The problem is that in a country like India, even today, we have a very, very limited resources for pre-surgical evaluation. There's always a fear of a permanent neurological deficit, and there's a low yield of long-term postoperative seizure and the lack of surgical expertise. So all of these factors limit us from using surgery as a good option in patients with drug-resistant epilepsy. So what is next? Neuromodulation. So what is neuromodulation? So neuromodulation is defined as an electrical stimulation of the nervous system to modulate or modify a specific function. So neuromodulation only considered in those patients where a resection or disconnection surgery is not possible. So those cases where the seizure appear to be originating from a multiple sources, one has to think of neuromodulation. The excitatory zone or the epileptic zone is located in an eloquent cortex, and patients whom multiple complex network appear to be the cause of DRE. A complete workup is required, including an epilepsy protocol MRI and a video EEG, recording at least 3 habitual ictal events. So patients where you have a multiple source of seizures, where the epileptic zone is located in an eloquent cortex and you have multiple complex networks where surgery cannot be done, you have to think about neuromodulation. So these are the 3 types of neuromodulation that one talks about. Of course, one is the deep brain stimulation, and which is very, very similar to what we use in Parkinson's and movement disorders. And then you have the vagus neurostimulator, and then you have a closed loop system, which is known as the responsive neurostimulation. So the open loop system are the vagus nerve, the deep brain stimulation, the TMS, that is transcranial magnetic stimulation, or the transcranial direct current stimulation. And in the closed loop, you have the responsive neurostimulation. So we just take all of these therapies one by one as quickly as I can. So the vagus nerve stimulation was approved as far as 1997, and it is an invasive open loop device. And in fact, I was fortunate to have seen the first patient of a VNS, which was done in India in Gangaram in about 2003 and 4. And it's basically an adjunctive therapy for both partial and generalized seizures. It is suitable both in adults and children, and it can be done in even an outpatient procedure. Of course, we don't do as an outpatient procedure here, and it has a proven profile in safety and efficacy almost about 25 years. And basically, in VNS therapy, what we do is we have a pulse generator on the diagram there, which is planted under the skin and is connected to the left vagal sheath at the level of the carotid sheath. So the efferent vagus nerve fibers are thought to increase the blood flow and metabolism in the region of brain associated with the onset of epileptic seizures. And in addition, these modulating nerve signals, they produce a reduction in seizure burden, frequency, and severity. So, so they are both kinds of current. The negative electrode generates action potential that travel efferently by the sensory fibers to the epileptic zones, where the efferent traveling action potential are mostly blocked by the positive electrodes. So VNS therapy, it delivers an anticonvulsive effect by multiple pathways. One of the pathways is it alters the neurotransmitter expression release by increasing the effect of the GABAergic neurotransmitters, serotonin and noradrenaline. However, it also improves the cerebral blood flow to the thalamus and the cortex, and it desynchronizes the ictal pattern. And all of these 3 effects have an anticonvulsive effect. So this is one of the effects on the excitatory neurotransmitter, where it prevents the release of glutamate, which is an excitatory neurotransmitter. It also improves the level of GABA at the neurotransmitter, which is an inhibitory neurotransmitter. And so it has an effect on basically on both glutamate as well as GABA. And this is one of the mechanisms through which VNS acts. So with VNS therapy, what patient has an improved seizure control, improved patient outcome with patients are treated in time, and a sustained improvement in seizure frequency and reduction in seizure severity and recovery time. And the quality of life, of course, improves when you have a decrease in seizure frequency. Your seizure severity also improves. So you have a good quality of life. It includes an improved mental functionings, good mood, and good behavior. So this is the latest model of VNS, and where you have an auto stim mode, in which the auto stim, basically the heartbeat sensing is done, and it delivers an automatic stimulation, and it works in conjunction with a normal and a magnet mode. So this is the latest in the VNS therapy, where you have an auto stimulator. And basically, as I told, that what VNS does is it improves the seizure control, decreases, has a long-term effect, and it reduces the seizure frequency, improves chances of recovery. So it also has a potential role in epileptic syndromes and also in status epilepticus. So venous therapy has very few side effects, and especially there because there's no interaction between venous therapy and other commonly used anti-epileptic drugs. And venous therapy usually has a mild non-pharmaceutical side effects. These could be paresthesias, increased cough, dyspnea, pharyngitis, voice alteration, and swallowing difficulties sometimes.
Dr. Anshu, sorry to 90 seconds remaining. Dr.
How much? Oh, chalo.
90
Anyways,
seconds.
VNS basically works on improving, as I told you, how it works. So venous therapy should be used in caution patients who have had a vagotomy. So a word about deep brain stimulation. DBS has been used in Parkinson for a long time. For epilepsy, it has been approved since 2018. And it's an option for people who seizure not able to treat with other types of epilepsy surgery. Here, you basically go put an electrode in the anterior thalamic nucleus, anterior nucleus of thalamus. And I will just basically, so DBS, it produces significant improvement in quality of life. It is found to improve attention and executive function, and both useful for both focal and generalized seizures. However, the side effects is implant site pain, infection, paresthesias, hemorrhage. Now, DBS is slightly more efficacious than VNS, but it is more expensive, requires frequent battery changes, and has a more elaborate surgical procedure. And finally, about the word about responsive neurostimulation. It was first approved in 2013. It's a form of invasive closed loop system. It's a feedback system which delivers electric stimulus to the seizure focus upon detection of epileptiform activity, hence aborting the seizure right at the onset. This is the most advanced system, and this is a closed loop system. And this is how basically the system is implanted at the cortex, and then you have a neurostimulator and the leads. So it's a closed loop system where this system basically monitors the brain activity continuously, detects patient-specific patterns, and stimulates automatically.
Dr. Anshu, time is up.
Yeah, I'm just going to summarize. Yeah, just a minute. I'll just summarize. So basically, these are the three systems that we use. The VNS is an open, it's basically an open system. Now it has been used as a closed because of the heart rate involvement. It has no recording capability and has an effect on cognition and mood. And the RNS is a closed system, and it is possibly one of the most scientifically and effective system. And DBS, of course, is an open system where you have to have an intracranial surgery. So to summarize, the long-term outcome data have been available for all these three modalities, and they suggest that the patient becomes stable and there is increased efficacy over the time, so this is neuromodulatory long-term effects. It is safe in patients, and rates of SUDEPs are low. Cognitive and mood improvement have been reported with both RNS and VNS. And long-term data are, of course, we have to see the long-term data. And because with some of the therapies, especially like DBS and RNS, we don't have very long-term data. VNS has a much more long-term data. But all of these therapies have shown that they are useful in patients where you cannot do a definitive surgery. And RNS has a unique advantage of recording and storing electrical corticography. Thank you for a patient listening.
Amazing talk, Dr. Anshu. Since we are waiting for Dr. Meena Dhamija oration, we cannot open the topic to the house. So can I hand over to the organizers, please?